The Subcommittee on Emergency Preparedness, Response, and Recovery will come to order. Before we start discussing today's subject matter, I'd like to take a moment to acknowledge the passing of Congressman Elijah Cummings. Mr. Cummings was a mentor to me on my arrival here in Congress, as this gentleman next to me was, and it is a very emotional day for quite a few of us. Elijah Cummings was truly a diplomat and a statesman, and irrespective of what side of the aisle you sat, he had respect for you. And he went through a lengthy illness, and I had opportunity to speak to him on many evenings and occasions because we had some of the same health issues. But this country's lost a great leader today, and I'd ask if we give him a moment of silence in his honor. Thank you, and I'd yield to the ranking member, Mr. King, for any statement he'd like to make.
Thank you, Mr. Chairman. I want to join with you in really mourning the loss of Elijah Cummings. He was a true gentleman, a very distinguished person to work with, and again, he was somehow managed to transcend the politics that too often drags us all down. So again, it's a great loss to the country, great loss to the House of Representatives, and I think all of us are proud to say that we served with him. I go back.
Thank you. The subcommittee is meeting today to receive testimony on defending the homeland from bioterrorism. Are we prepared? Good morning. I want to thank all of you for coming to today's hearing about the state of bioterrorism preparedness in the United States. I also want to thank the witnesses for testifying on this important topic. Bioterrorism represents a real, persistent threat to this nation. Biological weapons are relatively inexpensive, simple to deliver, and can cause mass casualties. Gram for gram, they are amongst the deadliest weapons created by humans. Even with a small quantity of biological weapons, a terrorist can cause massive harm to our society. The Department of Homeland Security's Countering Weapons of Mass Destruction Office has an important role in strengthening the nation's ability to prevent terrorists from using such weapons of mass destruction. Formed nearly 2 years ago, the Countering Weapons of Mass Destruction, or CWMD, is the focal point for the department's efforts to counter WMD threats. CWMD was created to centralize and streamline DHS's countering weapons of mass destruction programs into a single office that could enhance our defenses, share best practices, and leverage shared resources in unifying command. However, there have been several recent reports that raise concerns about CWMD. Even before these reports, our committee had concerns about the creation of the office. We were concerned that the reorganization would hurt employee morale, shortchange biological defense programs, and impact DHS's ability to carry out its important countering WMD terrorism mission. Recently, issues were raised about the technology behind CWMD's new biodetection system, as well as with cuts being made to several WMD counterterrorism programs. In 2018, the Federal Employment Morale Viewpoint Survey ranked CWMD as the lowest scoring office in the federal government. Previously, the office had been ranked in the top 20% of the federal government in terms of morale. Such a precipitous decline in the morale over the course of 2 years is an extremely concerning trend. Furthermore, the Assistant Secretary of CWMD, Jim McDonald, recently resigned, leaving CWMD without a permanent leader during this precarious time. I should also add that just days ago, Acting Secretary Kevin McElman announced that he was resigning. DHS is suffering a serious leadership drought and undoubtedly complicates the department's ability to execute its mission. That said, providing oversight to DHS is an important and timely function of this committee. We must ensure that DHS adequately is executing its mission to protecting Americans from weapons of mass destruction. Woo. Today, we will hear from witnesses who are on the front line of keeping the nation safe from bioterrorists. We will hear their perspectives on the threat posed by bioterrorists, the state of the national bioterrorism preparedness, and what DHS can do better to protect this nation from bioterrorists. This is an important topic, and we need to make sure that we are doing all we can to protect our nation from the threat of bioterrorism. I would like again to thank the witnesses for participating in today's hearing. I look forward to learning more about these topics and to hearing their testimony. With that, I now recognize the ranking member of the subcommittee, the gentleman from New York, Mr. King, for an opening statement.
Thank you, Mr. Chairman. As you know, our districts are very close. In fact, we're basically one terror target, I would say. Yes. So I want to, again, thank you for this hearing. I think it's very essential. And it's unfortunate that the witness with the Port Authority had to cancel last minute because it was literally the Port Authority that connects our states. Absolutely. And anyway, with that, I will read part of my statement and ask that the entire statement be included in the record. Mr. Chairman, since the horrific attacks of September 11th, the terrorist threat against the United States continues to grow and to evolve. In recent years, the desire to use non-conventional weapons has increased. Nation states, as well as terrorist groups, including ISIS, have sought to employ not only chemical and nuclear materials into their attacks, but have also shown growing interest in using biological warfare. The President's 2018 National Biodefense Strategy states that biological threats are, quote, among the most serious threats facing the United States and the international community. Not only can biological weapons sicken, disable, and kill innocent people on a massive scale, they can also inflict tremendous economic and social disruption. For example, pathogens directed against crops to induce crop failure could significantly cripple our agricultural system. The federal government has recognized the need to enhance the nation's abilities to counter against certain terrorist threats. Following 9/11, several programs were created to prevent terrorists using weapons of mass destruction. The Department of Homeland Security's CWMD was authorized in December 2018 to elevate and streamline these efforts. Unfortunately, recent reports have indicated that the CWMD office has significantly scaled back or eliminated the specific programs put in place to help protect the country. According to these reports, one eliminated practice included the work to update a formal, strategic, and integrated assessment of chemical, nuclear, and biological-related risks. This assessment provided guidance on the purchasing of detection-related technologies and medications following an attack. The CWMD office has also been heavily criticized regarding the BioWatch program, a monitoring system that collects and tests air samples for biological agents likely to be used in a bioterrorism attack. From numerous false alarms and delayed notifications of lethal pathogens to a questionable rollout of the second iteration of the program, Biodetection 21, BD21, it is clear that the CWMD office needs to do better. The bioterrorism threat is increasing and should be a priority. In 2015, I was the House sponsor of the First Responder Anthrax Preparedness Act, which requires DHS, in coordination with Health and Human Services, to carry out a pilot program to provide eligible anthrax vaccines from the Strategic National Stockpile to emergency first responders who may be at high risk of exposure to anthrax should an attack occur. While this is a step in improving WMD preparedness, there is a litany of threats beyond anthrax facing DHS and our state and local partners. It is imperative that our communities and first responders are well positioned to detect, protect, and decontaminate biological warfare agents. As the sophistication of biological weaponry improves, we must be ready. I look forward to hearing from our witnesses today on their perspectives on the growing threat and how well we are positioned to thwart any attack. As I mentioned, Mr. Perino, the Director of Preparedness for the Port Authority, was supposed to be here today. He cannot attend, unfortunately, and I would ask unanimous consent to insert his written statement into the record. And with that, I yield back.
Thank you, Mr. King. I want to welcome our panel of distinguished witnesses. Our first witness is Dr. Asha George, who is the Executive Director of the Bipartisan Commission on Biodefense. Dr. George is also a former staffer with the committee, and we are excited to see her here today. Welcome back. Next is Dr. Jennifer Rakeman. Dr. Rakeman is the Assistant Commissioner and Laboratory Director at the New York City Department of Health and Mental Hygiene. Welcome. And lastly, we have Dr. Umair Shah, who is the Director of Harris County Public Health in Texas and the past president of the National Association of County and City Health Officials. Welcome. And thank you all for being here today, and I look forward to hearing your testimonies on this important topic. Without objection, the witnesses' full statements will be inserted into the record. I now ask each witness to summarize his or her statement for 5 minutes, beginning with Dr. George.
Thank you, Chairman Payne. Mr. Chairman, Ranking Member King, Mr. Crenshaw, Mr. Guest, and the other members of the subcommittee, thank you very much for having me here today. I appreciate the opportunity to talk with you, and certainly as former professional staff for this committee, I'm particularly glad and honored to be here and recognize the congressional staff for their hard work to build this hearing together. On behalf of former Senator Joe Lieberman and former Governor and Secretary of Homeland Security Tom Ridge, who are the co-chairs for our commission, I am pleased to be here to talk about a terrible topic, bioterrorism preparedness and our ability to defend against biological attacks. Our other commissioners are former Senate Majority Leader Tom Daschle, former Representative Jim Greenwood, former Homeland Security Advisor Ken Weinstein, and former Homeland Security Advisor and Counterterrorism Advisor Lisa Monaco. I mentioned Senator Daschle, of course, because 18 years ago this week was when his office received an anthrax letter in the Hart Senate office building. That letter shut down that building for 3 months and certainly had a wide-ranging impact on all of the offices here on the Capitol. Homeland in particular wound up having to change its security protocols and continues, I know, to receive the occasional terrible white powder package or letter. It's still an issue for Congress, and it's still an issue for the nation. In October 2015, we released our first report, a national blueprint on biodefense, and that report contained 33 recommendations to cover the span of biological defense activities. So we addressed everything from prevention and deterrence through preparedness, detection, response, attribution, recovery, and mitigation, so all of it. All of the federal departments and a number of our independent agencies have a role to play and responsibilities for biodefense, and we tried to address as many of them as we could. One of our recommendations was for a national biodefense strategy. Congress put that in the NDAA for fiscal year 2017. President Obama signed it, and the Trump administration released it last year. Unfortunately, the federal government hasn't been able to get its act together quite yet to implement that strategy, but it's on its way, and at least we have a strategy for them to work from. I think it's important to remember that the nation is not adequately prepared and has not been adequately prepared for more than a decade now. And the hearings that this committee has held numerous times demonstrate that. Worse, current efforts to develop needed technology to detect the threat are insufficient and are going in the wrong direction. We often talk about the threat, and I know, Chairman Payne, you're very interested in hearing about the threat. We have nation-state and terrorist threats to worry about. Russia, China, North Korea, and Iran are all suspected now of maintaining their biological weapons programs, and Al-Qaeda, ISIL, and other terrorist organizations continue to be very vocal about their pursuit of biological weapons and have gone as far as to put training materials up on the internet to train others on how to execute such an action. So we need to do something about this. The threat is still with us, and it requires an active biodefense program, particularly by the Department of Homeland Security. So the department recognizes this, then nobody disagrees with this. And as you know, we put in place a BioWatch program back in 2003 of biological detectors throughout the nation. That system has not worked particularly well, as many of your hearings have demonstrated. And so the department decided to create a new program called Biodetection 21, BD21. We are not particularly supportive of that particular program. We'd like to see its goals be achieved to replace the BioWatch system with much better detectors, but their approach is flawed. They are not utilizing state-of-the-art technology to test. They're not using standard acquisition procedures, and frankly, they are not seeking the input of state and local folks that are actually going to have to respond to whatever happens with these. So, of course, in conclusion, I think there are a number of solutions, and they don't require tons of money or huge amounts of new legislation. And I'd be happy to talk with you about those further.
Thank you very much. I now recognize Dr. Rakeman to summarize her statement for 5 minutes.
Thank you. Good morning, Chairman Payne, Ranking Member King, and members of the subcommittee. I am Dr. Jennifer Rakeman, Assistant Commissioner and Laboratory Director of the Public Health Laboratory at the New York City Department of Health and Mental Hygiene. On behalf of Mayor Bill de Blasio and Health Commissioner Dr. Auxilles Barbeau, thank you for the opportunity to testify on New York City's biothreat detection efforts and ongoing work to prepare for and respond to public health emergencies. I am here today to discuss the vital role that public health plays in biothreat detection efforts and how the New York City Health Department collaborates with city agencies and coordinates with state and federal partners to prepare for and respond to emergencies. Our nation's public health and healthcare infrastructure play a critical role in protecting people from a range of hazards, including bioterrorism and infectious diseases. Local public health departments and their partners are on the front lines and are often the first to detect and respond to disease outbreaks. Core public health infrastructure at the local level requires state-of-the-art laboratories and electronic surveillance systems. We also need highly skilled staff, such as laboratory leadership, lab bench technologists, epidemiologists, informatics specialists, and emergency management and response experts who enable the people and systems to operate efficiently during emergencies. What we do every day at the local level is backed by our partners at the federal level, such as the Centers for Disease Control and Prevention and the Department of Homeland Security. For this system to work, each piece must be appropriately resourced and engage in ongoing, transparent communication and collaboration. As the largest, most densely populated city in the U.S., New York City is an international hub for business, media, and tourism. Consequently, we face a high risk of both intentionally and disseminated and naturally occurring hazards. A biological attack or large-scale infectious disease outbreak in New York City would significantly impact the health, security, economy, and political stability not only of the city, but of the rest of the country, and will have an international impact. The New York City Public Health Laboratory is a local laboratory that serves a population larger than that of most states. It has been central to the New York City response to the Amerithrax letters in 2001, the H1N1 outbreak in 2009, Ebola in 2014, Zika in 2016, and the recent unprecedented measles outbreak in New York. In addition, the New York City Public Health Lab, in coordination with the CDC's Laboratory Response Network, provides local diagnostic testing for emerging and highly pathogenic diseases, including Ebola virus disease and Middle East Respiratory Syndrome coronavirus, or MERS. 7 days after the 9/11 attacks in 2001, letters tainted with Bacillus anthracis, which causes anthrax, were sent to media companies and congressional offices. The investigation that followed resulted in a nationwide focus on bioterrorism and identified significant gaps in our ability to protect the public's health. In 2003, as a result of this investigation, BioWatch was created and quickly rolled out to a number of jurisdictions, including New York City. BioWatch is intended to serve as an early warning system of a widespread attack with one of a small number of potential biological threat agents. As the lead scientific agency for the New York City BioWatch program, the Health Department is responsible for the day-to-day technical oversight of the BioWatch laboratory testing and the development of environmental sampling plans to be deployed in the event of a BioWatch detection. While the Public Health Laboratory hosts the BioWatch lab, neither the PHL nor the New York City Health Department has input regarding the standard operating procedures and testing reagents used for BioWatch testing. Further, the local jurisdictions do not have detailed information regarding basic performance characteristics of the tests to which we are asked to respond. However, as the Public Health Lab Director, I am responsible for determining that a BioWatch result is valid and is a BioWatch Actionable Result, or BAR, to be reported to local federal partners and to determine what response actions will be taken. In 2010, after New York City experienced an unacceptable increase in the number of false positive BioWatch testing results, the New York City Public Health Lab revised the testing algorithm to differ from the National BioWatch Program standard to require additional verification to minimize this threat of a false positive bar. New York City has taken a leadership role nationally in pushing for a better system that provides reliable results. As the committee is aware, DHS is proposing to replace BioWatch with a new system, BD21, the intention of which is to detect a potential release in real near time. BD21 will use real-time detectors of biological anomalies in the field to signal the initiation of additional sample collection and testing. A biodetection program is an essential public health tool for a global city like New York. We understand the need for a reliable biodetection system and applaud the efforts to improve upon the current system, both in the timing of detection and the reliability of the assays. However, both BioWatch and the proposed BD21 systems fail to meet even minimum standards that any other test deployed in a public health laboratory would need to meet. While we support advancing the current BioWatch program to take advantage of modern biothreat detection technology, we have concerns about the deployment of this new program and the options under evaluation as part of BD21. Instruments currently deployed for military use, which have generated regular false alarms, are being considered for implementation in New York City and throughout the country. Biothreat detection system requirements for urban settings like New York fundamentally differ from the requirements for those used in military settings.
Okay, please wrap up.
The implications for launching a substantial response based on a false positive are far-reaching and will have associated morbidity and mortality. So it is imperative that DHS has an ongoing dialogue with other federal partners such as CDC and ASPR, and critically with local jurisdictions throughout this process. Chairman Payne and Ranking Member King, thank you once again for inviting me to testify today. Our concerns regarding BioWatch, BD21, and the need for a stable investment in public health preparedness are shared by cities across the nation.
Thank you. Thank you very much. Now I recognize Dr. Shah to summarize his statement for 5 minutes.
Good morning, Chairman Payne and Ranking Member King. It's wonderful to join you both and members of the subcommittee today. I also want to extend greetings to fellow Texans, Representative Green and Representative Crenshaw. I hope you too will join me in wishing the Houston Astros well against the New York Yankees.
Mr. Chairman, I object to that remark.
Hope that was not.
Can we cut this guy off?
Hope that's not considered a partisan statement. Thank you for inviting me to testify on this important topic. I'm joined by Michael McClendon, our Director of the Office of Public Health Preparedness and Response, and Albert Chang in our area of policy. My name is Dr. Umair Shah. I'm the Executive Director of Harris County Public Health and the Local Health Authority of Harris County, Texas, the third largest county in the U.S. I'm also the past president of NACHA, the National Association of County and City Health Officials, representing the nation's nearly 3,000 local health departments and its Texas affiliate, TACHO, which represents 45 local health departments across Texas. I'm also an emergency department physician at the Michael E. DeBakey VA Medical Center in Houston, where I've proudly cared for our nation's veterans for the last 20 years. Today, I'm here to testify on local public health's key role in emergency preparedness and response with respect to bioterrorism. I have limited time, so please refer to my full written testimony. Let me point out, though, that on the top of page 7, the testimony inadvertently refers to HHS when it should have instead stated DHS. Please note that correction. Today, I will touch on 3 main points. 1, public health truly matters, especially at the local level and in emergencies, yet it is largely invisible. I refer to this as the #invisibility crisis. This invisibility is a major issue in ensuring adequate capacity for preparing and responding to a myriad of emergencies. Frankly, our communities most often do not even know we are working on their behalf when we are. Number 2, emergencies occur repeatedly and unexpectedly, and public health must have strong tools at its disposal to protect our communities. Biodetection systems are important such tools, but even they cannot be used in isolation. Number 3, there is a science and an art to public health, just as in medicine, and we must have access and availability to as much information as possible to make decisions. This means that federal, state, and local partners must plan together today in order to protect our communities more effectively tomorrow. I speak to you as someone who comes from an impacted community. Since Tropical Storm Allison in 2001, we have responded to the H1N1 pandemic, West Nile virus, Ebola, Zika, Hurricanes Katrina, Rita, Ike, Harvey, and just this year, a resurgence of measles, 3 large-scale petrochemical fires, confirmed vaping cases, and most recently, Tropical Storm Imelda. No doubt Harris County has seen it all, but our story is one of a community of strength and resilience. Harris County Public Health is part of the Houston-Galveston Metro Area BioWatch Advisory Committee. The BAC is one of many such BACs across the country. In 2003, our community witnessed the nation's first BioWatch actionable result, a bar when low levels of Francisella tularensis were detected for 3 consecutive days. We eventually confirmed the detection was due to a naturally occurring source, but it took time to rule out a weaponized version. As many communities too have learned, a biodetection positive is not the same as a public health positive. While biodetection systems must be robust and accurate, effective and efficient, they are still tools within a well-established public health emergency response system. We cannot forget, no matter how invisible they may be, local public health personnel are the quote-unquote boots on the ground in ensuring communities are prepared for, protected from, and resilient to a variety of health threats. Much of the discussion today is focused on the science of biodetection. While I agree there is a science to public health decision-making, there is also an art. Despite the technologies at our disposal, this decision-making is based on the expertise of the individuals and agencies who are part of the process based on all available data points. This is why in medicine we ensure a finding from a diagnostic test is both confirmed and put into context of the patient in front of us. Local public health officials take other factors into consideration, including community concerns, as well as political, economic, and other ramifications for actions such as canceling large-scale events and how to respond. This is why locals must be a part of the equation. We cannot be brought in at the end. Ultimately, the decision of how to respond to a biodetection hit must be a shared one involving local decision makers and responders front and center. This means federal, state, and local partners must work together, as do public health and emergency management, law enforcement, and healthcare delivery, all partners alike. Ultimately, we are all part of the same team, and our communities expect it. Let me close by saying I'm honored to represent our amazingly resilient community, as well as the strong, dedicated public health professionals that give it their all as first responders in emergencies each and every day, not just at Harris County Public Health, but in the 3,000 such local health departments across the nation. I appreciate again the opportunity to testify today and look forward to your questions. Thank you.
Thank you. I want to thank all the witnesses for their testimony. I will remind each member that he or she will have 5 minutes to question the panel. I will now recognize myself for questions. Dr. George and Ms. Rakeman, the creation of the Countering Weapons of Mass Destruction Office was intended to enhance our defenses against biological terrorists and increase coordination and cooperation in the WMD mission space. Has the creation of the CWMD improved our preparedness for a bioterror attack?
Mr. Chairman, it has not. That office, unfortunately, has suffered from changes in the mission and goals and objectives for it since they started talking about creating it years ago, 8 years ago, as I believe. When you don't have a vision, the people perish, we know this, but they seem to have just spun down worse and worse as the years have gone by, these past 2 years. You mentioned the morale survey earlier, but in addition, they just seem not to be able to accomplish any of the things that they set out to accomplish. BioWatch has not improved, NBIC has not improved, DNDO is beginning to suffer, and they've lost a great deal of personnel, specialists that used to address all of those issues. So I would say no, it hasn't done what it was intended to do.
Dr. Rakeman?
I think also with the creation of CWMD, biological agents have been lumped together with radiological and chemical agents and are being approached in the same manner, which is an issue. You can't approach biological agents and detection of biological agents the same way that you can for radiological and chemical. Radiological and chemical agents are either there or they're not. Biological agents require detecting a specific agent in a mix of lots of biology and biological agents. And so approaching them in the same way does not work well.
So can those agents lay dormant for periods of time?
Well, it's trying to detect a very specific agent that you're concerned about in a world where we're surrounded by bacteria and viruses and things that are good for us and also bad for us. And so being able to pick out a select agent in that mix is a very different approach than looking for whether or not sarin gas is present or not, for example.
Yeah, I've been very critical of the BioWatch program. I finally ran across one of the units at the Democratic Convention. They had one in parking lot, and I walked by it. Oh, finally, I finally saw one. So, but it has not been the most successful way to do this. It almost seems antiquated science, from the 50s or whatever, with all the advances that we have. It's really amazing that that's what we're stuck with at this point in time. Dr. George and Dr. Shaw and Rakeman, all three. CWMD is creating a new biodetection space to replace BioWatch and the DHS current system. This new system is called Biodetection in the 21st Century, or BD21, and is supposed to address the shortcomings of BioWatch. Is the technology behind BD21 mature enough to address the issue of BioWatch, and how has CWMD worked with local jurisdictions to develop BD21 and solicit requirements for its use? Start with Dr. Shaw.
Yeah, thank you, Mr. Chairman, for that question. I think the challenge that we have is that we do not have a lot of information about this new system. And so when locals, and state partners as well, but locals are in particular not a part of the planning process, and we understand that there is sensitive information here that we're not going to be able to get everything shared, but we do believe that there is an opportunity to work with locals throughout this planning process. And again, that's how we're going to know better what the system is, what its limitations are, and certainly how we're going to be able to respond effectively to it in the future.
Thank you. Dr. Rakeman?
And I agree with Dr. Shaw. We are not confident in the maturity of the technology that's being deployed. It's technology that's been used in a military setting, which is not appropriate for an urban center like New York City or other cities around the country. It generates a lot of false alarms, which is a problem. Locals have not been given really any data and very little information about the system, and have not been pulled into good conversations about how to develop this process and make it work. So again, it's a technology that's potentially being pushed on locals without any input where we have to respond.
Thank you. And very quickly, Dr. George.
Mr. Chairman, I would only say just two things. One is that the system is predicated on the notion that state and local folks would respond immediately to trigger. But if they're supposed to respond, they ought to be included in the planning for the system in the first place. The other is that the DoD technology that's being tested was technology that was rejected by the Department of Defense. It did not test well in the operational field environment. And while it's good for DHS to try and test anything it can, I suppose, in the domestic environment, it's not like it started out with great results and DHS was then testing it. It's not mature.
Thank you. I'll now recognize the gentleman from New York, Mr. King.
Thank you, Mr. Chairman. Dr. George, just out of curiosity, there's no need to get specific. You mentioned Senator Daschle. Has his staff members recovered? Because I remember for several years afterwards, some of them were still pretty ill from that.
Yes, sir, they have recovered. But one of the things, if Senator Daschle was here, he would tell you this, that none of the people that were potentially or absolutely exposed to those letters were ever tracked going forward. Nobody paid attention to their health other than their bosses like yourself and Senator Daschle. There's no reason for that. The Department of Defense actually tracks people going forward if they've been exposed. I think that's a simple thing for the Department of Homeland Security to do now.
Okay, thank you. You talk with Senator Daschle, tell him I wish him the best on that. Dr. Rakeman and Chairman Payne and I, our districts are so close, and with the PATH trains and Amtrak, what happens in New York can happen in Newark, Newark can happen in New York. Does the city have the supplies necessary to counter deadly pathogens?
So that's something that's a little bit outside my area of expertise as a laboratory professional, so we can get back to you on.
Okay, if you would, yeah.
On that.
Also then, I guess if the city has its own vaccines stockpiled, or do you have to rely on the strategic national stockpile?
So again, we'll get back to you on that.
You would, okay. To all the witnesses, do you believe the federal government has successfully leveraged the private sector to increase bioterrorism defense?
So let me just,
Sure.
excuse me. Thank you for that question. Let me just start by saying that I think there are opportunities for working with, partnering with, and learning from private sector. I think there's a lot that we can really look at with respect to technologies, improving those technologies, but also in the distribution of medication supplies, stockpiles, et cetera. So I think there are some things that we can learn better as a federal government. That said, this is an emerging area. This is also an area that number of that has a number of unknowns that potentially can also be challenging. And so I think the proof in the pudding, if you will, is going to take some time for us to understand what better private companies might be able to, or private sector might be able to offer. But I think it is absolutely critical that the federal government does partner and explore all avenues to protect Americans.
Mr. King, I would say no. They have not. Of course, the department as a whole has struggled with leveraging and working with the private sector. But in this particular arena, I would say it's very hard for the private sector to even be involved if the office itself does not actually issue requirements for the technology that it's trying to utilize. They don't know where to connect. It's been an unnecessary challenge, but I would also say it's not just about industry. Academia should be involved, and then you have your sort of half and halves like the national laboratories. They're not involved as much as they could be or should be.
Dr. Rakeman.
I would agree with both of my colleagues on the witness panel here, and also add that again, more transparency and interaction with even local jurisdictions as well as industry partners, national partners. All of us are on the same team. All of us are looking to protect the health of Americans, and if we get all of our heads together, that's going to give us the best result at the end of the day.
Going back to Dr. George, parenthetically, and this goes beyond this particular issue, but I know one concern we've had for years that DHS has not worked with the private sector, for instance, to the extent that the Defense Department works with the private sector. And in many ways, it should be mirror images of each other. So I guess that still is a deficiency, but especially in this regard. But as you were saying, unless the guidance is coming, it's hard to make use of the private sector. With that, Mr. Chairman, I yield back. And also, thank you all for your testimony and your service. Really appreciate it. Good seeing you again.
Thank you, sir. We now recognize the gentlelady from Illinois, Ms. Underwood.
Thank you, Chairman Payne. Before being elected to Congress, I was honored to serve as a senior advisor to the Assistant Secretary for Preparedness and Response at the Department of Health and Human Services. And while at HHS, I had the opportunity to work on public health response and recovery efforts involving emerging infectious diseases, natural disasters, and bioterror threats. From my time working as a senior advisor to the ASPR and my work with BARDA, the Biomedical Advanced Research and Development Authority, I appreciate their evidence-based whole-of-community approach to planning, response, and recovery efforts, including in determining which threats to prioritize for development of medical countermeasures like vaccines, therapies, and diagnostics. I've seen firsthand how ASPR coordinates with CDC and local public health agencies on deployment and education. After reviewing your testimony for today's hearing, it seems that there's room for closer coordination between the Department of Homeland Security, local law enforcement, and local public health departments. So my question is for Drs. George and Shaw. HHS also plays a critical role in protecting and promoting public health. And as DHS seeks to protect the country from the threat of bioterrorism, they should ensure that they're coordinating with HHS. In your view, what could be done to strengthen that coordination?
Well, one thing I'd like to mention are the material threat determinations that DHS is supposed to be producing and sending over to HHS for them to respond to with BARDA's actions and others. It currently takes the Department of Homeland Security up to 2 years to produce one of these things, which is way too slow for the actual threat stream, which means then that BARDA has to sort of rush on its own with whatever information it can get. So that should work better. If DHS can't produce one of those determinations in less than 2 years, then we need to come up with something else. Otherwise, you're going to automatically have siloed efforts going down the pike.
Thank you so much. Dr. Shah?
Yeah, thank you for that question. My humble opinion is that a lot more can be done. I have an incredible amount of respect for Department of Health and Human Services, ASPR, as well as CDC. They do an incredible job. They support hospital systems. They certainly support local public health departments, state public health agencies. Just an incredible amount of work that goes in. And there seems to be a lot more of that cooperative agreement, a cooperative understanding, sharing of working together with, partnering with, and really leveraging the expertise and knowledge of local, states, tribes, territorial, as well as private sector, hospitals, et cetera, all coming to the table. That doesn't seem to be happening the same way with DHS. And so I think just the fact that learning from each other and how HHS is able to share with locals, I think that's an important commitment. But I do want to also point out that we recognize, again, as I said earlier, that there are sensitivities in a biodetection program. But there's also a trust that should be engendered with local public health officials, that we also are part of that spectrum. And so oftentimes we are then put into the category of, well, they're locals, they don't get it, they're not smart enough, or they're just not, we can't trust them enough with this sensitive information, and so therefore it's just not shared with us, and that's a terrible mistake.
And so would you characterize there have been an improvement since the Countering Weapons of Mass Destruction Office is now housing the health care aspects at DHS, or would you say that there's been really a dissemination of that relationship over at DHS?
It's difficult to tell, but I will say that we have noted that there was an earlier meeting, as you saw in my testimony, earlier meeting in Indianapolis, where locals did share concerns with DHS and CWMD about the sharing of information and really working together. And we're hopeful that that is going to start to show results. But that was the concern that was really articulated, is that you've got to work with federal partners, federal agencies across the spectrum, and also work with state and local agencies. And so certainly that's a perspective. I think it's also important to say, look, law enforcement and security oftentimes have different perspectives, not that they're wrong, but different perspectives than health. And so we have to really bring together both parts of the equation in order to be successful to protect our communities?
Well, one of the things that we're considering, and certainly with feedback from the Office of the CMO, the Chief Medical Officer, is trying to make sure that they have the authorities that they need in order to do their important work. And it appears that in this reorganization, some of those authorities have been stripped away or require additional levels of bureaucracy in order to execute the mission. And so, as you all might have some ideas or feedback about how to structure that, please be sure to pass that on to our office. And with that, I yield back. Thank you.
Thank you. I now recognize the gentleman from Texas, Mr. Crenshaw.
Thank you, Mr. Chairman. Thank you, everyone, for being here. I'll just start with a general question, which is, as we say in the military, we have a most likely threat and a most dangerous course of action or threat. For all three of you, what would you perceive to be the answer to both of those questions? The most likely threat that we face, I would say, so I guess the easiest way for someone to attack us, and the most dangerous potentiality that you might see. We'll start with Dr. George.
Mr. Crenshaw, I think the most likely is a terrorist attack or a small-scale nation-state attack utilizing biological agents, probably already weaponized. And I think the most dangerous course of action...
I'm going to dig into that a little bit more. How would they do that?
How would they do that?
So what's our most vulnerable points in our society? If you said weaponize a biological agent, but if you were to take a quick look at our infrastructure right now, what would you say is the most vulnerable?
Okay, so if I'm former military too, so I'm going to answer that question with a military answer. So you have to look and see what's going on throughout the nation right now. As a military person, if we were going to attack somebody else, we would look for vulnerabilities, but we would also look to see where are different critical infrastructure sectors or whatever the most busy. So places like New York and other metropolitan areas and rural areas that are currently struggling with naturally occurring diseases are already taken up and responding to some kind of crisis. If you add in the naturally occurring disasters and such, now you have another layer. So if you're going to attack with a biological weapon of any sort or a biological agent, you're going to go to those places which are very obvious on a map and attack there. In terms of weaponizing things, weaponizing a biological agent is not the most technically difficult thing in the world to do, and it's made even easier when you get your hands on already weaponized material from the former Soviet Union and other places like that. I would suggest to you that getting their hands on that material or producing it and then bringing it over here would not be that difficult.
Okay, and I've since you mentioned New York City, Dr. Rakeman, if you could answer that, what are your vulnerabilities in New York City? What do you see?
So I think one thing that as a nation that we need to be very careful about is maintaining the public health and healthcare infrastructure, because that's what we need in place to be able to detect and to respond to any biological incident, whether it is an intentional attack or a naturally occurring outbreak. And so making sure that we have stabilized funding and infrastructure in place, a laboratory that works, that we have the right instruments, we can get the right reagents and get a test up and running very quickly in an emergency. Is really critical, and sort of keeping that going. We've been in a place where we sort of fund our lab and buy new instruments and things from emergency to emergency rather than having things ready to go every single moment. We need to be able to do that.
Okay, and do you have that now?
So we did get a large influx of money after Ebola, and that helped us actually in one instance in the public health laboratory replace aging biosafety cabinets that were initially purchased with money that came after 9/11 and the Amerithrax attacks. So,
Dr. Shaw?
Sure, and I actually really like that last answer, Congressman. What I, as I said in my testimony, I really think one of the challenges is that we have this invisibility crisis, that we are really behind the scenes, and because we're behind the scenes, oftentimes there isn't the visibility, which then drives value, and when you have value, you have validation by either pro-health policies or pro-health funding. That is not happening, and so what happens is we're behind the scenes. People don't see what we're doing, so we don't get that investment that you get with the bells and whistles of a police car or a hospital or an emergency department physician, you start to really have a value proposition that goes into, well, public sector, public health, or even what's happening in local public health agencies, that's not as critical. But surveillance systems, epidemiological systems, working with our hospitals, the technologies, those are vulnerabilities. And so to answer your question, those vulnerabilities translate to if somebody is really looking at all this and then you pepper this with federal partners not sharing with local partners, now you have a state of either not as good capacity, or you have a state of confusion when you actually have a release. I think that's our biggest vulnerability.
Okay, so if I understand in summary what y'all are saying, you're not as concerned about whether they come through the water or they send a sick person through an airport. You're concerned more about our ability to respond to any of those events.
To detect and respond.
And to detect.
That's right.
Our commission is as concerned about the scenario you just laid out as with the ability to detect.
Thank you. I yield back. Thank you, Mr. Chairman.
Thank you. And before I recognize the next member, I now ask unanimous consent to allow Congresswoman Sheila Jackson Lee to sit and question the witnesses at today's hearing without objection, so ordered. And I now recognize the gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. I thank the witnesses for appearing, and I'm going to acknowledge the presence of Mr. Shaw from Harris County. Greatly appreciate your work over the years. Let me start with the concept that we have to embrace of CWMD replacing BioWatch with the BD21 system. The question has to do with the triggers. And the triggers that are proposed, it seems, may not be as sensitive as we would have them be. Can you give me some intelligence on how these triggers will perform in your estimation, if you have such?
Thank you, Congressman. Great seeing you again today. And I'm going to defer the scientific aspects to my colleagues, but what I would like to say is that one of the concerns that we had initially with the BD21 was that it seemed to skip a step when it came to locals being involved in even knowing that something was happening that was abnormal. And that was a very big concern that, for example, we and you know our local governance, our Judge Hidalgo, our emergency management, and our entire structure at the county, as well as with Mayor White and Mayor Turner and all of our colleagues at the City of Houston, there's an incredible infrastructure of local strength. And what we didn't want to have happen is that in the middle of something being detected, our federal government partners were finding out first, and we weren't even aware that something was happening. We're hopeful that that has changed, but that is one of the big concerns that we had. And then I'll defer to my colleagues on the triggers piece.
Thank you.
I think one of the major concerns we have with BD21 and our interaction with CWMD and DHS on this project is that we haven't really been given any information. We have no data on how the anomaly detection works, how well it performs. And again, we're being asked to start to think about developing CONOPS and response plans for this this system without knowing anything about its performance characteristics.
Mr. Green, from what we've been told, there isn't reliability and validity data on any of the detectors that are being tested as part of BD21, number one. Number two, it depends on trying to set some sort of normal baseline for whatever's going on around those detectors, and then eventually getting to the point where you could identify an anomaly. The problem is most of these detectors aren't set up for that sort of thing, number one, and number two, the department that's trying to do this, the Department of Homeland Security, hasn't been in the environmental airborne detection business for that long. If you're going to look at the background anyplace and look at things like pollen counts and air quality, you're going to go to EPA or some other department. So they don't even have that sort of history, a historical background to use with the system. Lastly, I would tell you that we've heard that the BD21 detectors go off at least one time a day wherever these 12 have been deployed thus far. They go off, but nobody knows what to do about it because they didn't get in place with a good concept of operations in the first place, or any direction to the state and locals, or any of the other federal departments and agencies like the FBI and DOD that might have to respond.
Next question. With the current BioWatch system, have you been privy to an actual testing of the system where you actually see it function so as to determine the efficacy?
I have never seen such a test done since its implementation. The last time I saw BioWatch or BioWatch-related technology being tested, physically being tested, was back when the original technology was rolled out for the Salt Lake City Olympics. One of the national labs actually produced the BASIS detector. I have not seen since then.
And what I would just add is that, as you know, 2003, Houston was the first BioWatch hit in the country, and we've learned a tremendous amount since then. However, I will say that with the bacterium that was discovered at that time, we were being told that this is an act of intent or terror immediately, regardless of what was happening, and turned out over time learning that it was really naturally occurring bacterium. And that's a big challenge, and this is why it's not just the science of the biodetection, it's the art of public health coming together and really putting all that intel together to make decisions.
Well, thank you very much, Mr. Chairman. I yield back.
Thank you. Now recognize the gentleman from Mississippi, Mr. Guest.
Thank you, Mr. Chairman. Dr. George, you state in your report that the Bipartisan Commission on Biodefense in October of 2015 presented findings and recommendations to this committee. You state in the report that you made 33 recommendations, and then you later, on page 2 of your report, state that 4 years after the release of the initial report, the nation remains unprepared for bioterrorism and biological warfare with catastrophic consequences. My question to you is, of those 33 recommendations that were made some 4+ years ago, what progress has been made to make sure that those recommendations are being carried out?
Thank you, Mr. Guest. Some of our recommendations have been taken up. We had 33 recommendations and 87 associated action items. Of those, I would say about 17 have been taken up by Congress in various pieces of legislation. The reauthorization for the Pandemic All Hazards Preparedness Act, the Farm Bill, the National Defense Authorization Act, and others. In terms of actual execution, however, I would tell you that the third recommendation for a national biodefense strategy has been completed. The Trump administration released that last year, and they're in the process of implementing it. And other activities have been taken up by the federal government itself without legislation or the White House having to push them to do it. Strides are being made in terms of biological attribution, in terms of addressing the One Health concept of animal, environmental, and human health all coming together. The State Department has taken some forward steps in terms of addressing the Biological Weapons Convention requirements. And the Judiciary Committee here has been working on strengthening the law to make the possession of biological agents and working with biological agents more of a criminal activity.
And so, from your answer, roughly half of those recommendations there's been some action on. Would that be correct, Dr. George? I think you said 17. Did I get that number correct?
I would say probably 10%.
Oh, only 10%?
Yeah.
Right. Of those that have those recommendations that we've not yet taken action on, which of those do we need to give the highest priority to?
Gosh, I think this issue of biodetection certainly is a high priority, and I think that our recommendations on preparedness for the public health and healthcare communities are also high priority. I believe we need a stratified hospital system so that we know where to send patients wherever those patients might might find themselves. We can't assume that everybody that's going to become ill from a biological agent is conveniently going to be around the 4 or 5 Ebola treatment centers that we have right now.
And let me ask you, also talking in your report, you mentioned North Korea and Russia, that they continue to develop biological weapons. You say China will invest between 2015 and 2020 $12 billion in biological innovations. You also mentioned Iran and terrorist organizations. As it relates to terrorist organizations, you talk about different biological agents, including anthrax. Where would a terrorist organization most likely obtain a biological agent? Would they manufacture those themselves? Would they be obtained from a country such as Iran or North Korea? Based upon your expertise in this area, is it more likely that they will internally be able to produce a biological agent, or would they be more likely to partner with North Korea, Iran, China, Russia, one of the nation states that currently are producing and possess biological weapons?
Sir, I think it depends, honestly. It depends on the terrorist organization and the resources that they have available to them. If they have the resources, if they can get them and they can get the scientific expertise, they'll try and produce them themselves, because that would just be easier logistically. Otherwise, you'd have to determine whether those organizations have a relationship with the countries you just mentioned, or whether they're able to tap into the black market and somehow get already weaponized material out of the former Soviet Union and other countries like that, and just already have weaponized material at their disposal.
And one last question, ma'am. I know my timer is running short. In previous meetings and reports, the Commission has highlighted the importance of partnering with the private sector. Can you provide examples of how the private sector, specifically the medical countermeasure manufacturers, have partnered with the U.S. government and ways in which we can improve this public-private partnership in which we are working together to keep the American public safe?
Sir, I think where it has worked best is when the United States government has been very clear on its requirements, so that the private sector knows what it's responding to. A great example would be what happened with Ebola. We had the industry had a very specific disease it was going after. It knew where various locations were at, and the Department of Defense, the Department of Health and Human Services, and others were very clear on what it was they were looking for. So now you can see today, we don't just have one vaccine, we've got all kinds of things happening now because they knew what they were shooting for.
Thank you. Mr. Chairman, I yield back.
Thank you. I now recognize the gentlelady from Texas, Ms. Jackson Lee. I'm sorry. Oh, I apologize, sir. We will now go to the gentleman from New York, Mr. Rose. I apologize.
Thank you, sir. No need for an apology. Dr. Rakeman, thank you for your service, first of all, to New York City. Are you familiar with the unit at Fort Hamilton base that moves to major sites, whether it's the Thanksgiving Day parade or whatever else it might be, and has biodetection technology?
I am not, and I can get back to you with more information on
Okay, well, this unit does exist,
Yes.
and they do certainly move from...
CST unit?
What's that?
The CST unit? Civil support team, yep.
So my concern is that when they are on site, they have basically detection technology there. And it takes about an hour to determine if something is hazardous or not. In the event that that CST unit is not on site, let's say US Open, whatever other large-scale event in New York City, what is the time that it takes from identifying whatever it might be to actually having a confirmation that it is hazardous?
So using the BioWatch system, which in New York City can be deployed and is often deployed at big special events, such as, the New York Yankees games, things like that, and events like the U.S. Open, the city will deploy PSUs to those events.
A PSU is...
Portable sampling unit. It's the unit that's on site that actually draws in the air sample.
And they have the same technology as a CST?
The CST technology is not something I'm particularly familiar with.
Dr. George, do you want to add anything to this?
No, sir, it's different technology.
How is it different?
I can't tell you that, sir. It's just, it's different technologies, actual different pieces of equipment.
Is it worse? Is it better? Is it, I mean,
I don't have that data, sir.
okay.
You'd have to
So,
get from DOD.
so the PSUs, you said, right?
Right, so it's BioWatch testing. So then the filter would come back to the public health laboratory and be tested.
Wait, so the PSUs can't test it on site?
No. No,
So
all
what-
BioWatch testing, the samples
So
come
what do
back
they
to-
do then?
So they're collected by our partners in the field,
Okay.
the filters, they come back to the laboratory, and we process and test those samples at the laboratory. So in New York City, depending on where the sampler is and if it's a special event, the sampler will be operational for a period of time, up to 24 hours, it could be less. So an attack may have occurred 24 hours prior to when the sample is collected. Then that sample needs to be transported to the laboratory, processed and tested, and that takes a number of hours as well. So the window between when something may have happened and when we actually have a positive BioWatch actionable result in the laboratory can be over 24 hours up to 36 hours.
And so what is our right now, first of all, is that okay, 36 hours in terms of the timeline? Is that too long?
So
It seems to me that
the
is
goal
too
for
long.
fire detection, and one of the goals of the BD21 program, is to shorten that time to detection, and that is something that we definitely support.
What would you like to shorten it to?
Well, to pick up an attack, to be able to save lives, hours count. So as short as that window can be, the better it is.
So Dr.
However,
George, what do you think it should be?
You know, sir, the right answer to this is it should be immediate or near immediate. The reason she's saying that it's taking so long is because what's happening with the current BioWatch system is that it's just a system of filters that's filtering air, and somebody's got to test it. The system itself is not testing it. So if you had better handheld detectors that could identify something quickly and with valid and reliable results, or you had better detectors or whatever.
And that technology exists?
Technology exists, but none of that technology is perfect yet. So all of it requires gold standard testing back in a laboratory as of right now.
But we
I think
do
that's
have.
that was the key message, is that it's the confirmatory test. You certainly don't want to launch a response when you don't have the confirmation.
And the tests that are
Sure.
deployed need to be good, reliable tests.
But we do have the technology right now for mobile laboratories, correct? Does that technology exist?
I'll defer, but we still, the mobile does not have the confirmatory component.
Okay.
So it still requires you going back to a public health laboratory or a LR response network laboratory to actually confirm.
Well, but right now in New York City, based off our SOP with the NYPD, obviously we would evacuate a site once there was any level of confirmation, correct?
So if we had a full BioWatch actionable result that we determined, and me as a laboratory director is responsible for determining whether our result is valid, which is, then the response would happen, and that's something that we partner with NYPD to determine what.
So right now, if you found something in Grand Central Station, and I'm sure this has happened before, and you send it to the lab, it takes 36 hours. So really what New York City policy is right now is that we find something that is potentially hazardous, we wait 36 hours before evacuating?
No, so it might take 36 hours to determine whether there is a reason to go back and do follow-up sampling to determine whether there was a true agent in that facility at that site.
So how long does that take?
Well, then that can add on more hours.
So basically I'm asking, how many hours does it take for us to find out whether this stuff kills people? Do you have a number for that?
I don't have a number for that. We can get back to you. We'd have to talk about the entire system and work with all of our partners to come up with that number.
Who's in charge of that entire system in New York City?
There are multiple city agencies that work.
There's not one person in
There's
charge?
not one, no.
So there's not one person in charge in New York City right now of managing a biohazard response?
So there's a public health piece to the response that the health department is responsible for. There's a law enforcement response that the law enforcement teams are responsible for.
Okay. So we have some interesting questions here, because I'm a simple guy, right? I just want to know that we can quickly get people out of large areas by quickly finding out that there's a hazardous item there.
And the gentleman's time has expired, and we will, if we can come to a second go around, we can get back to that.
Thank you.
I recognize the gentlelady from Texas, Ms. Jackson Lee.
Chairman, let me thank you for your generosity and kindness for allowing me to sit on a very important panel for a committee that I have invested my legislative career, the Homeland Security Committee, but I want to thank you particularly for your well-suited leadership on this committee. And I look forward to working with you in being a problem solver for some of the very issues that these very fine witnesses are espousing, particularly in the FEMA overhaul. One of the things that we are stifled by is the structure of funding from the federal government. The Stafford Act, for those of us who have experienced disasters, Hurricane Sandy, you saw it firsthand. Your local folk coming out of city council, I came out of city council, your local folk needed their resources and they knew what they needed to do. And so my line of questioning will be to these witnesses on that very order. But as I do so, I would be remiss not to speak about my friend, Dr. Shaw, who has responded to all of the public requests that I've made dealing with public health. Let it be very clear that we have worked together on public matters. I am reminded of the Zika virus and the work and the promptness and the astuteness that Harris County Health engaged in. Dr. Shaw is a collaborator with the Houston City Health Department. We worked on Ebola. No, the first case was not in Houston, it was in Dallas, but we were well recognizing, as the rest of you were, that we needed to be on point because Ebola took to the flight aviation system and people were traveling. We worked on this question that doesn't get you a lot of fans, and that is about supporting vaccinations. When we were having a moment in our community wherein people seemingly were rejecting the value of vaccinations, that's a public health scenario. For example, one does not know if those untoward Russian bots could influence people. Let's don't get vaccinated. We know what will happen. We had a measles outbreak in a number of places. And then, of course, the idea of gun violence. So let me make some pithy questions, yes or no. I want to get back to Dr. George, and I want to thank her for her service. I want to thank her for the 2014 report that you worked on so diligently. Just give me, has the government responded to that report and some of the valuable aspects of it?
Yes.
In its totality or portions thereof?
Portions thereof, and I think you'd
Tell me where we could get in there in a better way for some of the...
I think where Congress could act would be to take those activities that are halfway through and push them, show some interest.
Give me one activity and push through.
Well, I think BioWatch is the topic of today. I think BioWatch would be one that could be pushed.
That we need to profoundly try to refine and define and
Yes,
make it
ma'am.
work. You also, someone said the BD21 has data that you haven't discerned whether it's reliable. Is that accurate?
Correct.
So that is certainly a part of our work that we really need to encourage and work with the private sector. We need to refine the reliability of that data.
Correct.
To both, I'm going to go to Dr. Shaw first, but let me ensure that Dr. Rakeman, see if my glasses are working, can ask in your leadership. But you made a very important statement that the bells and whistles of public health are not conspicuous. If you're working on Zika, maybe the neighborhood of which you may be doing the complementary mosquito spraying, which is another agency, but you work with them to do what they're supposed to be doing, is not a real bell and whistle unless somebody is looking out their window at about 9 o'clock at night. But there are other aspects of public health that you're working on. And therefore, when it comes to funding, you may not be in the forefront. Tell me how devastating that is and how we need to change the federal construct that we're dealing with so that public health, particularly in bioterrorism, can be front and center. Dr. Shaw and Dr.
Sure, and thank you, Congresswoman, for your leadership and your support of public health. We really appreciate that. Your ongoing support is critical to what we're wanting and trying to achieve in our local community, so thank you. I think that the real rub of this is, at the end of the day, is to ensure that locals are part of that planning process. I mean, emergencies happen in local communities, local governance, local responders, local partners, local community members who are impacted, and we want to make sure, and you've highlighted many of those issues that have occurred in our community, but also the vast number of emergencies that the Houston, Harris County, and Southeast Texas, as well as Texas throughout, has had in terms of emergencies over the years. We have to ensure that that experience is respected by our federal partners, that it is not that the federal partners know it all and they simply say, you know what, we're going to tell you exactly how this is going to happen. It should be a cooperative partnership, and that is not always happening, and I think that is the concern.
Doctor, would you respond? Thank you, Dr. Shaw.
Thank you, and I like Dr. Shaw's hashtag of invisibility crisis, because that really is something that's an important aspect of what we do in public health. Our job is to keep people from getting sick, and to sort of put that on a banner or put lights and sirens around that is very difficult. And so making sure that state and local governments are part of the conversation when it comes to things like funding or programming, and is very important, because what we do needs to have infrastructure, and that needs to be there always. We don't know when the next outbreak is going to happen. We don't know when the next crisis will occur, but if the infrastructure is not there ahead of time, then we can't respond.
And let me quickly ask you this. You heard me talk about the construct, which is federal, state, and then maybe, would it be helpful that if we had a definition of a crisis, an emergency, a natural disaster, man-made disaster, that you're getting a direct emergency infusion of dollars? Would that be helpful to you all as leaders in your community on healthcare?
Yes.
And it would be defined to the particular incident or the definition of incidents that would occur that would be able to direct monies directly to those local agencies. Dr. Reichman?
So getting funding to local agencies is very, very important. And funding that is, particularly for emergencies, is important and necessary. What can be hampering is if funding dollars are tied to specific events and that we can't use them for other things, because building that infrastructure is important. The same instrumentation we use in the laboratory to test for a foodborne outbreak is instrumentation we use to test for Zika or to test for Ebola. So having all of that there and being able to spend the money in the way that makes our work most efficient and makes us most nimble is really critical.
We would listen to you and how that would be designed. Dr. Shaw?
Yeah, and as you know, that it's not an either or. It's not just the emergency funding coming. It's really building that capacity throughout, so you have a higher level of capacity, and so you don't have to stretch as much when you have a surge in an emergency. But I think, as you also know, Congresswoman, there is also that concern about looking at how federal agencies really send those dollars down to local partners, local health departments, and ensuring that it's not just going, for example, to a city core, but really it's looking at all the risk threats and all the community members that are potentially, like in Houston, Harris County, where you have 2.2 million that are within the city of Houston, but you have 2.5 million outside of the city of Houston, also looking at a whole community approach to that funding. So I think looking at funding streams and funding formulas is absolutely critical so that we can get this correct.
Okay.
I know my time is long spent, Mr. Chairman. Thank you. Thank you to the witnesses. As I close, may I just have a letter of collaboration from the city of Houston, and may I just extend a question that we can work on. Part of their issue is being blocked from getting information because of it being classified as classified, or that they're not at that level. And so I think this is a very perfect entity to work on solving some of those structural problems, funding problems,
Yes.
so that we can fight this war of bioterrorism. Thank you. I yield back, Mr. Chairman, for your courtesies.
Thank you. I'd like to ask unanimous consent to enter into the record the bipartisan report of the Blue Ribbon Study Panel of Biodefense from October 2015. And I want to thank all of you for your testimony.
I'm sorry. Mr. Chairman, did you get this one too, the letter that I offered on unanimous consent to be offered?
Without objection.
Correct. Thank you, Mr. Chairman.
I want to thank the witnesses for their valuable testimony and the members for their questions. The members of the subcommittee may have additional questions for the witnesses, and we ask that you respond expeditiously in writing to those questions. Pursuant to Committee Rule 7D, the hearing record will be held open for 10 days without objection. Hearing no further business, the subcommittee stands adjourned.